start now. So good afternoon or good evening. So today we have 60 questions. So it is we have group 1, group 2, group 3 of pathology question. Okay. I will start by pathology again. We'll start by thyroid. 22 years old female undergoes thyroidectomy. The resected specimen show non-encapsulated tumor with papillary projection and pale empty nuclei, what we called it orphan Annie, and summoma body. Summoma body is microcalcification. Which one of the following is appropriate histological diagnosis? This is common question and also common in our undergraduate IMU. So anyone know what is this picture look in which cancer? Which thyroid cancer?
Papillary, Prof.
Yeah, so this is papillary thyroid carcinoma. You can notice that papillary thyroid carcinoma occur in young age, occur in 20. So this female, of course, in female 22 or 20 age. And usually they have look empty, but it's not empty because the nucleus in the periphery, and they have microcalcification, what we call this summoma body. So this is papillary thyroid carcinoma. Papillary thyroid carcinoma is spread by lymphatic. Second question, in thyroid also a thyroidectomy specimen from the 43 years old lady show mass with prominent exophil cell, what we called it her cell. A scanty thyroid colloid, what is the following appropriate histological diagnosis? This is not common, but is one of the varieties of some of the carcinoma. Does anyone know which carcinoma of the thyroid can give this hair cell? Okay. So this is variation from follicular carcinoma. Follicular carcinoma, the aggressive type, is called hair cell. So it is variety of the follicular carcinoma. Again, as you see here, papillary occur in age of 20, follicular occur in the 30 and 40. Medullary and anaplastic occur in older ages. Okay, 32 years old lady undergoes thyroidectomy for mild goiter. Of course, goiter is increasing of the size of the thyroid, whatever it is benign or malignant. The resected specimen to show intense lymphatic infiltration with acinar destruction and fibrosis. Which one of the following is appropriate histological diagnosis? So this patient have lymphatic deposition. If you see the thyroid tumor, as in past, thyroid tumor, either follicular, anaplastic, medullary, papillary. This is 4 type of thyroid carcinoma. We don't consider lymphomas or lymphatic deposition as a cancer thyroid because it is occur not in the normal thyroid, occur in the thyroid have some diseases. So which disease can occur in the thyroid can be complicated by non-Hodgkin lymphoma or lymphoma. Anyone know what is disease can occur in thyroid complicated by lymphoma?
Hashimoto's.
Yeah, Hashimoto's thyroiditis. So we don't consider lymphoma as primary thyroid tumor because it's not occur in normal thyroid. It is occur in the patient have Hashimoto's thyroiditis. Hashimoto's thyroiditis complicated by lymphoma. So non-Hodgkin lymphoma occur in the thyroid is due to complication of Hashimoto's thyroiditis. Hashimoto's thyroiditis usually patient have a goiter and tender. Usually goiter is not tender. If the patient have goiter with tenderness, so usually it is thyroiditis, and in thyroiditis, they characterized by sometimes thyroid hormone is very high, sometimes it's very low. Okay. After that, a 20 years old girl presented with a thyroid cancer with no significant family history. On examination, they have a nodule in the left lobe of the thyroid with a small district firm mass separate from the gland, most probably lymph node. So this patient is young, 20, no family history of the thyroid tumor. They have a mass, and this mass, of course, it is lymph node. Sometimes the presentation of some cancer in thyroid is only presented or first presented by lymph node. So again, this is young and have lymph node. So what it could be? Anyone?
Papillary, Prof.
Yes, so papillary again occur in young, 20, characterized by lymph node enlargement because it's spread by lymphatic, because follicular is spread by blood, anaplastic and the medullary can spread local then by lymphatic. So papillary again occur in young, spread by lymphatic, not run in family. The cancer who run in family in the thyroid is medullary thyroid carcinoma because can be part of multiple endocrine neoplasm. After that, we have some question is related to thyroiditis and hyper or hypofunction of the thyroid. Usually in exam, we give you between brackets the normal value. 33 years old man, recovery following prolonged, protracted stay in the ICU, recovering from anastomotic leak following difficult transhiatal esophagectomy. His progress is slow and intensive care doctor receives the following thyroid function. TSH is 1 unit, so which is with a normal, a little low. T4 is with a normal, 8. T3 is from 1 to 3 is little low. So what is the following is most likely diagnosis. So they don't have high T3, don't have low TSH, but all is within normal but low. So what it could be? And this patient in the intensive care and have long disease or in intensive care. So this is what we call it sick euthyroid. So it's okay if the patient is long stay in ICU, whatever the cause. So they have some of the low function thyroid. We call it sick euthyroid. EU mean normal. 28 years old female presented to the general practitioner with a symptom of fever and diarrhea. A part of diagnostic evaluation, the following thyroid function tests are obtained. TSH is less than 0.1. So it is very low. T4 is 30, which is very high. T3 is little high. So this patient have high T4, have low TSH. So what's your diagnosis? This is simple. If you think it is simple, anyone?
Hyperthyroid, Prof.
Yeah, so this is just a typical hyperthyroidism. You can find not necessarily T3, T4 is high, can be one is high, can be other is little high. So it is high thyroid hormone, low TSH, so it is hyperthyroidism. 19 years old lady presented with palpitation. It is important to know palpitation is not necessary in thyrotoxicosis. It can be in thyrotoxicosis and also can be in hypothyroidism. And the blood sample from the thyroid function as the following. TSH is more than 6, so it is high. T4 is 12 with a normal. T3 is with a normal. So this patient have high TSH. So it means that the TSH need to compensate the low thyroid function. So this is a typical case of hypothyroidism, because in hypothyroidism, the TSH try to compensate, so he can bring it to within normal. But it is take a time. After that, he is difficult to control. So you can find it is still high, but T4 and T3 become more lower. So this is a case of hypothyroidism. Just remember, it's not necessary to have palpitation. Mean toxic can be both toxic and hypothyroidism. So hyper and hypo can cause increased heart rate. Again, common question, from which of the following cell type giant cell granuloma common originated? Of course, granuloma occur in tuberculosis. Granuloma occur in inflammatory bowel disease, especially Crohn's, but not in ulcerative colitis, and in other foreign body granuloma and others. So granuloma is aggregation of, a very common question in exam, it is aggregation of what?
Macrophage.
Macrophage. So aggregation of macrophage become epithelioid cell, and epithelioid cell mill a circle. We call it giant cell granuloma. Next question, 39. This is question, in some question you have a picture. So I show you the picture later. So 46 years old lady presented with symptom of diarrhea, weight loss of 10 kilo, and the skin rash of erythematous blisters. Involving the abdomen and the buttock. These blisters have a regular border and both intact and ruptured vessels. What is most likely? This is not common disease, and this is the picture. They have diarrhea, they have weight loss, and if you can see, this is, of course, difficult to be in selenoma, difficult to be pancreatic adenoma. So by exclusion, you can find it is glucagonoma. So it is increase of glucagon is one of the characteristics. Although it is rare disease, can cause diarrhea, weight loss, and specific skin rashes. We have a lecture later about skin disease or manifestation of the skin disease, skin manifestation of systematic disease. Next question, and very common, 54 years old man presented with symptom of neuropathic facial pain, weakness of the muscle or facial expression of the right side. On examination, they have hard mass, approximately 6 cm anterior to the right external auditory meatus. Of course, mass in front of external auditory meatus, it is parotid mass. So this patient have parotid mass, and this parotid mass is hard, so it is malignant. And because it is malignant, it affects the facial nerve. So you must have a malignant disease. So polymorphic adenoma, not a malignant. Sjögren syndrome is dry mouth, dry eye, and different. So we have two cancer, either acinar or adenocystic. They found that the neuropathic or the neuronal invasion or invasion through neural sheath is occur in adenocystic carcinoma more than acinar carcinoma. Although both can affect the facial, but common with adenocystic or adenoid cystic carcinoma. So the answer here is adenoid cystic carcinoma. If you don't mention adenoid cystic carcinoma, so any parotid cancer can be the cause. Of course, sarcoidosis and all these can cause bilateral parotid swelling or bilateral facial affection, but it is improved by corticosteroid. Of course, cancer is difficult to be bilateral at the same time. Next question, and also difficult. 56 years old man undergo radical nephrectomy. The pathologist plaster of the kidney identify pink fleshy tumor of renal pelvis. What is most likely? Actually, for me, even this question is difficult because we don't see much the gross anatomy of the organ. Maybe in some museum you can find it, but I bring these two pictures. So you can find transitional cell carcinoma is pink in color. It is cut section without dye. And the renal cell carcinoma, which is common, is yellow-brown in color. So here he asked about cut section of the kidney and pink fleshy tumor. So this is pink color, is transitional cell carcinoma, which is not common. And the other, which is not mentioned here, renal cell carcinoma, or sometimes they call it hypernephroma, and they give yellow-brown color. Okay, just remember this is one of the difficult questions. Next question is a 65 years old man presented with hemoptysis, suspected suffering from lung cancer. On examination, they have a large supraclavicular lymph node. Which of the following feature is most likely to be present on histological examination? So this patient have hemoptysis, suspected lung cancer. So of course they have a cancer. This is supraclavicular lymph node, is left supraclavicular lymph node. So it is characteristic of the malignancy. Of course, a lung can be right and left because it is not GIT. So in any malignancy, if you can see here, what is the character of malignancy here? Which one can be malignant character?
Increased mitosis.
Yeah, increase mitosis because it's character of malignancy. Of course, the character of malignancy, whatever the cancer, nucleus is increase nuclear cytoplasmic ratio, hyperchromatic, deeply stained. Of course, apoptosis is programmatic cell death, can be physiological process. Bar body is something in chromosome. Multinucleated giant cell organelloma are the same word, and it is aggregation of macrophage and occur in tuberculosis and in Crohn's disease. Next question, very common. 65 years old man, hypertensive, diagnosed as abdominal aortic aneurysm. It is common disease in UK. Which of the following pathological explanation describes this effect? If you see the cut section of artery, especially big artery, you can find the lumen. It is like mucosa in the intestine, but here we called it intima. After that, we have the muscle layer and contain elastic lamina. After that, the covering is adventitia. It is like serosa in the intestine. So you can find to have abdominal aortic aneurysm, you must have defect in this muscle in the media area. So the answer is something in the media. But which one is responsible for dilatation of the artery in the media? Is a collagen or elastic fiber? So the easy way, just to remember, to be stretched, you must have elastic fiber. So loss of the elastic fiber in the media, in the muscle layer, can cause aortic dilatation. Okay? So the answer here is loss of elastic fiber in the media. Of course, adventitia is not related. It is just covering. And the intima is not related. So the only defect in the muscle layer, which is media, elastic fiber, is the cause of the aortic aneurysm. We speak about acquired aortic aneurysm. Next question is about 28 years old lady has malignant melanoma. Melanoma, not necessary to mention malignant. Melanoma mean malignant. It is common in Australia, common in UK, and common in exam. Removal from his calf, which is the following pathological character carry greater prognostic weakness. Of course, you need to know that in the melanomas, we have two scoring. We have Breslow thickness and have Clark level. Breslow thickness is a measurement done under microscope. So under microscope, you measure. You can see, for example, it is good prognosis if it is 0.7 millimeter. Bad prognosis if they reach 3.5 millimeter. So it is the thickness and seen under microscope. But Clark is level, like it is affected the till subcutaneous, we call it level 5. It is superficial, so it is level 1. So Clark level 1, 2, 3, 4, 5. But thickness, it is 0.7 till 3.5 millimeter. So it is less than half centimeter. So back to the question. So here, the prognostic criteria is only for Breslow thickness, because vascular invasion, abnormal mitosis is occurring in all malignancy. Perineural invasion can occur in any malignancy. Lymphatic infiltration occur in any malignancy. So we depend on the thickness or penetration, which we called it Breslow thickness, and it's seen under microscope because must be magnified. Of course, melanoma, Breslow thickness, and the Clark level is very, very, very important. Okay. The next question, 28 years old lady breastfeeding her first child. It is important, usually if we mention first child, it means that the lady have no much experience. So about cleaning of her breast and the areola and the nipple, so the mastitis and abscess is very common. She presented with comfort in right breast. Clinical examination demonstrate erythema and flaccton area. Aspiration show pus. Culture was done. Which of the following may be the cause of organism? So again, lactating female, first baby, they have something in her breast, like swelling in her breast. And if it is the swelling is diffuse, we call it mastitis. If localized, we call it abscess. But here he don't ask about this, he ask about the organism. So of course, the organism is Staph aureus. In some questions, they ask about which antibiotic to give the lady. Of course, we give her antibiotic not affect the baby, so it's best to give cephalosporin. But if she is not non-lactated, you can give fluoxacillin or any antibiotic. But cephalosporin is the safest if she is lactated because it is safe in the baby. The only antibiotic we don't give it to the mother or the young baby is tetracycline because can affect the teeth. So the answer here is Staph aureus. Next question is tricky and difficult, and it is about 56 years old man diagnosed have glioma of the brain, from which of the following cell type tumor originate. Then actually glioma is from neuroglia. But all other tumor like astrocyte can cause astrocytoma, but it is a special cell in the brain. Oligodendrocyte is from melanin sheaths. Epidermal cell, it is from glia, ciliated glia. The squamous cell not having in the brain, and neuroglia is the cause of glioma. Okay, so you have some question maybe tricky because no one interested in the neurosurgery tumors. Next question, and very, very important. Usually come even in orthopedic. 63 years old man find he must stop walking after 100 yards due to bilateral calf muscle. He finds that bending forward and walking uphill help him to relieve the pain. He can ride a bike without any pain. What is most likely underlying cause? This is common question, I think, in orthopedic and IMU and the undergraduate. Anyone know the answer of this? The patient who, when leaning forward, the pain in his lower limb is decreased.
Lumbar stenosis.
Okay, this is good. So usually in some scenarios, they mention a lady go to for shopping in supermarket, and when they push the trolley, they found it is easy for her, no problem. After that, when he back and stand up, they have the pain again. So leaning forward or pushing a trolley, or as mentioned here, go to bending forward or walking uphill. So this is characteristic of lumbar canal stenosis. It's very common, and you have surgery for lumbar canal stenosis. Very important, come frequent in orthopedic. This is simple, just a 73 years old lady admitted for laparoscopic cholecystectomy. During her preoperative assessment, he noticed that she received furosemide. Furosemide is a diuretic. We call it loop diuretic. Trade name is Lasix. If we found R up superscribed, it means that it is trade name or mark. For treatment for hypertension with proposition of sodium that filtrated. So this scenario is not related to the question. The question, what proportion of sodium is filtrated in glomeruli will be subsequent excreted. Okay, you know, in the we have the nephron. The nephron is consistent of the glomerulus and the proximal convoluted tubule, lobe of Henle, and distal tubule and the collecting tubule. So you can find some material or most of material is totally absorbed from the glomerulus, the others like water from distal and convoluted tubule. But sodium is absorbed in each part with some material. Like for example here, sodium filtrating glomerulus is up 25, because in other parts, sodium is go to with water, like in distal convoluted tubule by the effect of aldosterone, so salt to water retention. But in this time, he filtrated directly, the same for glucose, because most of the glucose also in the glomerulus, but sodium is about 25. The rest of sodium with water under the effect of aldosterone in distal convoluted tubule. It looks like a physiology more than pathology. Next question, a 59 years old man presented with recurrent episode of urinary sepsis. He has suffered from recurrent attack of left iliac fossa pain over the past few months. He has also noticed bubble in the urine. Bubble in the urine, so the patient say, in my urine, I found like no water, but I feel something come out, or I found air or found bubble. So this is called pneumo mid-air turia. Like hematuria is blood, this is pneumoturia. CT show large inflammatory mass in the left iliac fossa. No other abnormality. What is the following diagnosis? So this patient have no loss of weight, is not a cancer. Can occur in cancer, but in this patient, not a cancer. And of course, they have a fistula between colon and urinary bladder. And this fistula is due to inflammation because the patient have some or inflammatory mass or tender mass in the left iliac fossa. So what it could be? Anyone? Patient have hematuria due to mass in the left iliac fossa, and this mass is inflammatory. So what is your diagnosis?
Diverticulitis.
Diverticulitis, good. Okay, so this is diverticulitis. So diverticulitis, not diverticulosis, because diverticulosis don't cause fistula. Diverticulitis can cause fever, can cause leukocytosis, and they can cause colovesical fistula, and they can cause bad odor of urine and hematuria. Can happen in the cancer colon also, but usually the patient have high tumor marker, have loss of weight, no tender mass in the left iliac fossa, and also can be one of the presentation of cancer of the diverticulitis or cancer colon. After that, we have lung cancers. Lung cancer is somewhat tricky, but we have general rules for lung cancer. First rule, if the patient have lung cancer and the chronic smoker, so straightforward, it is a squamous cell carcinoma. If the patient have lung cancer and the non-smoker, so it is adenocarcinoma. So first, smoker, squamous cell. Non-smoker, adenocarcinoma. Second, if the patient have a tumor central, so it is a squamous cell carcinoma. Central like mean inside the lung, in the halo of the lung. If the tumor is outside, so it is not central, so can be adenocarcinoma. After that, if the tumor in pleura, not in the lung, it is not lung cancer, it is mesothelioma. So pleura is mesothelioma. Chronic smoker, squamous cell carcinoma. Non-smoker, adenocarcinoma. So you can go to one by one. So first patient, 73-old heavy smoker, presented with hemoptysis. On examination, section and show evidence of clubbing and high parathyroid hormones. Imaging show a main bronchial tumor with a massive mediastinal lymphadenopathy, together with widespread visceral metastasis. So what type of lung cancer most likely? This is question have one trick. Because again, we mentioned if a smoker, it is squamous cell carcinoma, and a smoker is adenocarcinoma. But if the patient, if a smoker, and they have paraneoplastic syndrome, so it is a small cell carcinoma or oat cell carcinoma. What is paraneoplastic syndrome? Can be anything, can be high erythropoietin, high parathyroid hormone, high SCTH, any hormone increase, we call it paraneoplastic syndrome. So in this situation, we called it small cell lung carcinoma or oat carcinoma. Okay, so in this patient, smoker, cancer lung, typical cancer lung, but this patient have what? Have paraneoplastic or hyperparathyroid hormone. So this is a case of a small cell carcinoma. If no paraneoplastic syndrome, so the answer is squamous cell carcinoma. The next question of the lung also, 68 years old female who's never smoked, so it's not a squamous. presented with mass in the periphery of the right lung. So non-smoker, adenocarcinoma, periphery, adenocarcinoma, periphery of the lung, not in the pleura, because pleura, as we mentioned, it is mesothelioma. So non-smoker, periphery, adenocarcinoma. Smoker, central, squamous cell carcinoma. Smoker, paraneoplastic, small cell tumor. So next question. 85 years old man who presented with caverned hemoptysis have modest smoking history 15 back a year. He found to have tumor located in the right main bronchus. So here the tumor is central. And again, when the tumor is central, chronic smoker, so till now it is a squamous with no evidence of metastatic disease. He decided not to undergo any treatment and remain well for a further 12 months before develop symptomatic metastasis. What type of lung cancer? So this type of lung cancer is squamous. So just to summarize, squamous cell carcinoma, of course, in a smoker, slow growth, typically central. However, small cell carcinoma will not associating with the survival of the year without treatment, so it is rapid growth, and usually small cell carcinoma is characterized by paraneoplastic syndrome. Large cell, which is rare, one of form of non-small lung carcinoma, develop an outer of the lung, tend to be grows rapidly, spread more aggressively than other parts. So just to summarize, if the patient smoker and have tumor central and have all sign of malignancy, so squamous cell carcinoma. If the patient is non-smoker and the tumor in the periphery, so it is adenocarcinoma. If the tumor in any part of the lung with paraneoplastic syndrome, so we called it a small cell carcinoma. Large cell carcinoma is very rare and aggressive. If the tumor in pleura, especially in asbestos worker and factory worker, so it is pleura and we called it mesothelioma. So just smoker squamous cell, just SS, and in the central, and adenocarcinoma, non-smoker, and in periphery. Of course, lung cancer in the Western countries is the commonest cancer because of the smoking. So this is why it's common. It's a common cause of death because till now we don't have real treatment or correct treatment or good treatment for this type of cancer, maybe in the future. Next question. 63 years old male presented with several episodes of painless terminal hematuria. Usually, if the patient have painless hematuria, painless jaundice, painless whatever, usually it is not a good sign and it is indicate malignancy, especially in old people. He suffered from chronic obstructive airway disease or pulmonary disease secondary to long-term smoking. Here, we don't speak about cancer lung, but he need to know that smoking can cause many cancer, can cause cancer lung, can cause cancer esophagus, can cause cancer in the kidney, ureter, and urinary bladder. So here, this patient have painless terminal hematuria. It is important to remember what we mean by terminal, because terminal, if the patient say, I have hematuria initially with urination, so most probably it is something in urethra. If it is terminal, so can be from the kidney, can be from the bladder. Okay. Usually, urinary bladder or smoking can cause cancer bladder. Cancer bladder, if we have no parasite, nothing, so it is called transitional cell carcinoma. If the patient have some parasites like schistosoma, which is called bilharziasis in some country, like in Egypt or Japan, like schistosoma japonica, they can cause metaplasia and squamous cell carcinoma. We can find in other versions. So this painless terminal hematuria, so something in urinary bladder, so we call it transitional cell carcinoma. Of course, nephroblastoma occur in baby. Renal cell carcinoma is hypernephroma and can cause hematuria also, but not necessary to be terminal, and usually mass and polycythemia. Adenocarcinoma of the bladder is occur 1% and occur in urachus, which is the connection between urinary bladder and umbilicus. So it is very rare. Next question. 70 years old man or male presented with painless frank hematuria. On clinical examination, left varicocele. Routine blood test reveal polycythemia, but otherwise normal. So this patient have triad. This triad is painless hematuria, not mentioned here, but mass in the left kidney or right kidney, polycythemia. Of course, in male, they have varicocele, and this is what we called it secondary varicocele. Secondary varicocele mean that if you make the scrotum up, suppose this is the scrotum, and you make it up, so the veins is not empty. This is called secondary varicocele, because if the left is the scrotum up, the vein become empty. It's still congested, so it is secondary varicocele. So the triad of painless hematuria, kidney swelling, polycythemia is a triad for renal cell carcinoma or adenocarcinoma of the kidney. And if in male patient can be associating with, if it is in left side, by left varicocele. So this patient have adenocarcinoma of the kidney or renal cell carcinoma of the kidney, or the old name, not common use, is hypernephroma. Next question is also tricky, for me at least, but who work in pediatric, they say it is common. A male infant born premature at 34 weeks gestation by emergency cesarean section, low birth weight. He initially appeared to be stable. However, over the ensured 24-hour, he developed worsening neurological function. What is the following process is most likely to have occurred? So in pediatric or doctor who work in intensive care or neonates, they have an idea if patients become worse, deteriorated, and comatose. If it is premature, the common cause of that is intraventricular hemorrhage. It is brain hemorrhage. This is have no explanation. It does not mean that he have a female formation or congenital anomaly, but it is just a statistic variation. They found that the immature baby in incubator or intensive care or neonates, if deteriorated, usually it is due to intraventricular or brain hemorrhage. Of course, it is not extradural. Extradural occur due to trauma. Subdural occur due to trauma and old age. Subarachnoid occur in AV malformation like perianeurysm. AV malformation or AV, it is like perianeurysm is the same and can cause subarachnoid, but they found intraventricular hemorrhage occur in baby. Okay. 43 years old man presented with dysphagia, difficult to swallow, or dyspepsia, undergo upper GI or OGD. During the processes, diffuse gastric and duodenal ulcer are indicated. Colo test, which is Campylobacter-like organism, confirm presence of H. pylori. What is most likely explanation for this ulcer? Actually, this is a simple question. Whatever the cause, peptic ulcer can be due to many diseases. Like, for example, stress can cause what we called it stress ulcer. Head injury can cause something called Cushing ulcer. It is stress ulcer also. Burn causes something called curling ulcer. It is a stress ulcer. Stress causes stress ulcer. But the gastrin, if it is high, gastrin high can cause Zollinger-Ellison and cause peptic ulcer. If the calcium is high, is as in case of hyperparathyroidism, calcium increase gastrin increase HCl, so the patient will have peptic ulcer or gastric ulcer. So whatever the cause, what is the main factor in all this to cause ulcer? If you see the option here, which factor written here is the main cause of ulcer or the end result to cause an ulcer? Anyone? Just think simple.
Increase acid production.
Yes, so simple. Whatever the cause, as the end result is increased HCl secretion. So suppose patient have high gastrin, zolingal ilson, gastrin increase HCl. The patient have hyperparathyroidism, calcium is increased, calcium stimulate gastrin, gastrin increase HCl. You have stress, and you have some sympathetic and some parasympathetic, so the disturbance of this can cause increased HCl. You have cut of blood supply to mucosa and shedding of the mucosa due to ischemia, and followed by irritation of the stomach by HCl. So whatever the cause, the main cause is HCl. So acid production is the main cause. Of course, we need to treat the cause, whatever it is, high gastrin or hyperbara or stress or whatever. After that, 25 years old male, pedestrian, is involved in RTA. He sustained multiple injury and admitted to ICU. Intubated, ventilated. Over the next week, he developed ARDS. ARDS is adult respiratory distress syndrome. The main reason for hypoxemia in this condition. Of course, we know that ventilation, perfusion, or mismatching is a big problem in the lung. Ventilation means the air goes outside. Perfusion is the blood. So if we have something in the ventilation, like restriction or obstruction, affect the lung function. If you have something like embolus or lack of blood supply, it also can cause ventilation, perfusion mismatching. So in ARDS, his question is something in ventilation or perfusion of the lung. It is mechanical obstruction like bronchial asthma or ischemic bronchitis, or it is effect of lung perfusion and affect diffusion of the blood through the lung. What is your answer? Which one you can choose in this answer? If you take it one by one, increase lung compliance, it is not increase, it is decrease. Reduce diffusion is correct. Reduce surfactant is correct in baby. What we called it, surfactant is from pneumocyte type 2, and you have some disease called hyaline membrane disease, and it is cause respiratory distress in baby, called hyaline membrane disease. And this is why we called it an adult respiratory distress syndrome, because it is not lack of surfactant congenital, it is something induced. And the reduced elastase is not related, left to right shunt is not related. Okay, so we have also respiratory distress syndrome in baby if he have lack of surfactant due to underdevelopment of pneumocyte 2, which is secrete surfactant. But the ARDS is affection of ventilation perfusion, mainly perfusion of the cell. Next question, very common. 48 years old woman presented with recurrent loin pain, fever, investigation reveal stag horn mean big stone or stereotyped stone in the left kidney. What is the following organism is the cause of the infection? Anyone have suggestion what is the positive organism? This is big stone. So why it is big? Because to be big stone, so they need more precipitation of the calcium. Calcium precipitated in the alkaline media. This is explain why in bone we have alkaline phosphatase to make the media alkaline so the calcium can precipitate it in the bone. So the same in the kidney. If you have a stone kidney, urine is acidic. So if urine become alkaline, so the calcium precipitated and the make stone, and this is big. Only one organism cause alkaline urine, which is Proteus. So if the patient have Proteus infection, the urine become alkaline, the stone become big, and become very big, occupying the whole pelvis of the kidney. And this is why staghorn usually, or big stone usually, with Proteus infection. So now the media is alkaline. I need the media to be acidic. Of course, I don't ask the patient to drink hydraulic acid or sulfonic acid because it's dangerous. So I need to give the patient acid, but at the same time, it is safe. So which vitamin is acidic, you know?
Vitamin C.
Vitamin C. So you give the patient a lot of vitamin C. So vitamin C will be excreted in the urine. So the urine become acidic. So they kill the Proteus and the patient infection is improved. But of course, we need to destruct the stone. So the answer here, this patient have Proteus mirabilis. So this Proteus is the main cause of big stone. Of course, the other can cause UTI, except staph epidermidis. So E. coli can, Klebsiella can, staph can, but it not cause big stone because it is not cause alkaline media. After that, we're back to facial nerve. Facial nerve is very important. And again, we have many topics in facial nerve. They have these 3 questions about facial nerve. First, to differentiate between upper and lower motor neuron lesion of the facial nerve, if the patient can elevate eyebrow, can close his eye, so it is upper motor neuron region, like in a stroke. But if the patient unable to elevate eyebrow to close his eye, so it is lower motor neuron lesion, and usually due to parotid tumor. And the common tumor can cause that, it is adenocystic carcinoma. So if the patient have injury in the parotid, facial affected, all this half is closed, unable to elevate the eyebrow or close the eye. If able to do that, so it is a stroke and it is upper motor neuron lesion. Of course, the cancer not come bilateral. If come bilateral, most probably it is sarcoidosis and improve by corticosteroid. And diagnosed also by chest X-ray, you can find hilar lymph node of the sarcoidosis. So this is all related to facial. So we can start one by one. So 22 years old man presented with symptom of lethargy, bilateral facial nerve palsy. On examination, bilateral parotid gland enlargement. Which one of the following appropriate diagnosis? Of course, it's difficult to have bilateral tumor. So what's your diagnosis here? Anyone?
Sarcoidosis.
Okay, so bilateral, young patient, sarcoidosis. If it is adenocystic carcinoma, so unilateral. Cerebrovascular accident cause upper motor neuron lesion, unilateral and not in 22. Buttress temporal fracture, unilateral. Wharton trauma, adenolymphoma is not affect the facial nerve because it's still benign tumor. 21 years old man presented with unilateral facial palsy. So it is young, so it is not a tumor. After being hit in head on examination, they has right side facial nerve palsy and the watery discharge from the nose. Watery discharge from the nose indicate what? CSF coming from the nose, so this patient have fracture base. And this fracture is some anatomical related to the facial nerve. If you remember the anatomy of facial, and he come at the end from stylomastoid foramina in anatomy. So this area related to the petrous temporal bone fracture. So if the patient have fracture in petrous bone or petrous temporal bone, can affect the facial nerve and cause affection of the facial nerve, and usually unilateral. And must be have severe trauma. Severe trauma can characterized by raccoon eye, by battle sign behind the ear, by CSF come from the nose, from the ear, and all these are indication of fracture bone or base of the skull. Last question is still ENT, a 43 years old lady presented with symptom of chronic ear discharge, right side facial policy. On examination, they has foul smell, fluid drainage from the right ear, and the complete right side facial nerve policy. So this patient have something in the ear. You know that facial nerve is related to the ear in many sites. Especially he come from a stylomastoid and have a course related to the upper part of the inner ear. So this patient most probably have severe infection in the middle ear, and this is infection, we called it cholesteatoma. So this is cholesteatoma in the ear and can affect the facial nerve. Again, polymorphic adenoma not affect the facial. Sarcoidosis can be bilateral. Wharton tumor not affected. Petrous bone is unilateral and affect the facial. Okay. So this is as regard the first group of the pathology question. As you see, pathology question is general question. So you can find it in the same question. You can find the same question, the same scenario coming again in the paper 2, because we speak about thyroid tumor, we speak about many tumor. Can come in the ENT part of the paper 2, because we speak about otitis media and facial policy and the facial affection and sarcoidosis. So they usually all are coming, so either coming in pathology or coming in surgery or surgical specialty. After that, we have some question related also to pathology. We're still in pathology. This is today we will finish pathology. I just have another 30 question I share with you. Okay, this is the last group of the question. Of course, as you see, pathology usually is easy topic. Anatomy pathology is one of the easy topic in exam. Pathology, so we start by GIT, gastrointestinal. Something may be related some to an embryology in patient with annular pancreas, which is most likely site of obstruction. So anatomical, of course, we know the pancreas is lie in the curvature of the duodenum. So if the pancreas become annular, so it is covered this area. So which area is affected? So which part, of course, you know, duodenum is 4 parts, but 1, 2, 3, 4. So which part of duodenum is affected in annular pancreas?
Second
Anyone?
part.
Second part. So it is easy, embryological second part of duodenum. Next question, the idea of this question, just to know, if you have ulcer in the stomach, gastric ulcer, if you have duodenal ulcer, which is common, duodenal ulcer never turn malignant. Duodenal ulcer impossible to turn malignant, can perforated but never turn malignant. Gastric ulcer can perforated but can turn malignant. Normal gastric ulcer usually in the lesser curvature. If it occur in greater curvature, can turn malignant. So whatever the ulcer in duodenum, never turn malignant. Can cause metaplasia, can cause something, but never turn malignant. So this is why he asked 53 years old man presented with dyspepsia and upper endoscopy, finding redness of the mucosa, loss of mucosal fold, ulcer in first part of duodenum, so now in duodenum. So he take a duodenal biopsy. Duodenal biopsy, they found mucus-secreting epithelia, resemble cell of the gastric antrum. H. pylori, Helicobacter pylori, is identified by clue test. So this patient have H. pylori. And this is some sort of the metaplasia in duodenum. So which of the following is most likely explanation? So what is happened? This is duodenal metaplasia. Duodenal metaplasia, again, never turn malignant, but lower esophagus metaplasia, which is esophagus, turn malignant. This is metaplasia is changed from adult type to adult type, or well-differentiated type to well-differentiated type. It is like in the lower esophagus, instead of squamous cell carcinoma, become stratified columnar with goblet cell, like intestine. The same can occur in the cervix of the female, which is normal squamous. It is simple stratified columnar and become squamous cell carcinoma. So it is the reverse of the lower esophagus. Both cervix metaplasia, lower esophageal or esophagus metaplasia can turn malignant. Duodenal metaplasia never turn malignant. 43 years old man is recovering following emergency Hartmann procedure. Of course, the Hartmann procedure occurs on left side of colon, usually in cancer or diverticulitis, to bring the two ends outside. Performed for obstructive sigmoid cancer. You know, rectosigmoid cancer is a common type of cancer in colon. Pathology report moderate differentiated adenocarcinoma, which is common. Invading muscularis propria. So invading muscularis propria, so it means that it is T, because T1 superficial, T2 invading muscularis propria, T3 penetrated muscularis propria, T4 come outside the colon. 3 out of 12 lymph node is involved, so 3 lymph node mean N1, because N0 no lymph node, N1 from 1 to 3, N2 more than 3 lymph node. With metastatic disease, no distal metastasis, so M0. So this patient can be considered as T2, N1, M0. But he don't ask about TNM staging. He asked about Dukes. Of course, what mentioned first, extraocular stage, you don't hear about it. It is historical. Sometimes because in the Royal College, we have 5 options. In the traditional Malay exam, it is only 4 options. So they usually, we don't found, because Dukes is A, B, C, D, so they don't found else to say there is something from the history. So never to be the correct answer. So this patient is not come to the other organ. If it is invading the liver, for example, become D. If just limited to the colon, it is A. Is become in the wall, but no lymph node, it is B. Is involved with the lymph node, it is C. So this is Dukes C. Again, the important to know A, B, C, D for Dukes, that A is good prognosis, it's 95% 5-year survival. D, very bad, 25% 5-year survival. B, about 70, C, about 50%. So this is important to know, Dukes. So this is A, B, C, this thickness of the colon. Superficial is A, whole thickness is B, whole thickness and the lymph node is C, metastasis is D. Next question, 56 years old man, diagnosed as abdominal aortic aneurysm. Again, abdominal aortic aneurysm is an important topic and common in England. A CT scan done to assess the size of the aorta. It is important to know the size of the aorta, because if it is more than 5.5 centimeter, it is big size. If it is more than 7, it is urgent operation. More than 5, we follow up the patient every 6 months by ultrasound to measure the size of the aorta. The normal size of the aorta or diameter of the aorta is 2 centimeters. During his investigation of adrenal gland identify, this is what we called it incidentaloma. Incidentaloma means accidental finding. Usually adrenal tumor is discovered by chance. But here he say it is well circumscribed lesion, so it is benign. Clear separation and no extension into surrounding structure. So this patient is have abdominal aortic aneurysm. They follow up him. They found a tumor in the adrenal gland, and this tumor is benign. Normal echogenic, so it is benign. Measure 1.5 cm, so it is not big. And the gland is otherwise normal. What most likely diagnosis? So this is mass in the adrenal and the benign. So of course it is adrenal cortical adenoma. If he say it is cystic containing fluid, so can be adrenal cyst. It's not common. We have adrenal cyst, but in kidney we have cyst in the kidney is very common. Polycystic kidney, not common, but can happen. Of course, it is not metastasis because adrenal metastasis is very, very, very rare because it is highly vascular organ. AV malformation is rare also, so all these are rare. So the only is adenoma. Pheochromocytoma can occur in adrenal gland and can increase catecholamine. Patient presented by hypertension. This is why in young people is presented by hypertension, we're looking for adrenal gland and renal artery stenosis. Of course, the pheochromocytoma have a tumor marker in the urine. We called it phenylmandelic acid. After that, we have a lot of the questions related to the murmur of the heart. It is somewhat related to physiology, repeated many times. I have in the answer sheet a list of the murmur, what you found. You can find the scenario is fixed, but what it changed is the type of murmur, like mid-diastolic here, early diastolic here, some else you can find another type of the murmur. So this is very important. They consider as physiological questions. Sometimes they include it in the pathology. So start one by one. 28 years old woman, positive family history of Marfan syndrome. If we mention Marfan syndrome, I think we have one before that. Okay, sorry, we have one before that. 28-old Indian woman. If you mention, of course, this exam is a British exam. So if you need to mention something is very rare in UK, like rheumatic heart disease. Rheumatic heart disease is impossible to happen nowadays in England. So they can mention it is overseas, foreigner, traveler, mention other country. But if not mention a country, so we consider the patient as British patient. Is not Malaysian, is not Middle East, so it is important to know. I found in some questions they mentioned Singapore. They consider Singapore as one of the Asian countries can have rheumatic fever, although it is not true, but they are still thinking that Singapore and India and Malaysia, you can find some rheumatic heart disease. 28 years old Indian with a history of rheumatic heart many years ago, with 18-week pregnant, presented with increased shortening of breath, chest pain, cough, clear sputum, apraxia, so no fever. Her blood pressure is 140/80 millimeter mercury, heart rate 130, saturation is 94 on the 15-liter oxygen, which is a big amount. Maximum on examinations is mid-diastolic murmur. There are bilateral basal lung crepitation, mild beta edema, and usually bilateral. It is with heart failure. Suddenly deteriorated respiratory arrest, chest X-ray show with white of both her lung. What is the most likely diagnosis? So the key here is mid-diastolic murmur occur in which disease of this? So mid-diastolic murmur occur in mitral valve stenosis. In mitral valve regurg, we have pansystolic. In mitral valve stenosis, we have mid-diastolic. So this is just to differentiate. So the key of all this scenario is type of murmur. If you know the type of murmur, you know the diagnosis. The same here. So here is mid-diastolic. 28 years old woman, positive family history of Marfan syndrome. So in the previous case, we mentioned rheumatic heart, so you can have valve disease. But here they mention Marfan syndrome. Marfan syndrome is autosomal dominant disease, affect the collagen. The patient usually is tall, hyperlaxity, can have a lot of disease like laxation of the lens, joint can be abnormal movement. So this is most of these people work in circus for acrobat and others. What is considered as is the aortic aneurysm, and Marfan characterized by thoracic aortic aneurysm, not abdominal aortic aneurysm. Of course, thoracic aortic aneurysm, the first branch from aorta, give it to what? Which part of body? What is the first branch of aorta? Anyone? From anatomy.
Trapezocephalic trunk.
Say again?
Trapezocephalic trunk.
No. Before that. Give it to the heart. What is the first branch of aorta? It's coronary. It is not a big branch, so usually we consider the big branches. So if the patient has thoracic aortic aneurysm, they affect the blood supply to the coronary, to the heart. So this is mimic ischemic heart. And I see one case in Sramban, they have the same. She have presented many times to the hospital with chest pain, consider ischemic heart, is found cardiac enzyme is normal. So at the end, by echo, they found they have thoracic aortic aneurysm. Okay, so back to this scenario. So Marfan syndrome, so can have thoracic aortic aneurysm. In 30-week pregnancy also presented with sudden onset of chest pain, associating with loss of consciousness. Blood pressure is 170 over 90 millimeter mercury. Saturation in the 15-liter oxygen is 93. Heart rate 120. Anorexia. So it's on examination, the early diastolic murmur. Occasional bilateral basal crepitation. Betal edema, ECG, ST elevation lead to 3 and AF. So this is picture of early diastolic murmur in Marfan syndrome, something related to the aorta. Of course, thoracic aneurysm can be started to give this picture, and this condition, we called it aortic dissection. But this ECG is mimic aortic regurg. But in aortic regurg, they have also early diastolic murmur. So this is mimic aortic regurg. But the cause here, because of Marfan, is aortic dissection. Of course, aortic regurg is not from the option. But suppose I remove aortic dissection and write aortic regurgitation, it is correct answer. Okay, this is ECG picture is mimic ischemic heart. So this patient have aortic dissection and affect the blood supply to the heart. So give ECG mimic to ischemic heart or coronary. Of course, one see Marfan think in aorta is easy. Okay, after that, we have another question, maybe late about this, but we're back again at the end. 28 years old woman with 18-week pregnancy presented with sudden chest pain, blood pressure 150 over 70 millimeter mercury, saturation R92 on the 15-liter oxygen, and her heart rate 130, no murmur. So here, no murmur. Chest is clear. There are signs of thrombophlebitis in her left leg. What is most likely diagnosis? So she is 28, pregnant. They have thrombophlebitis in the left leg, no murmur in the heart, and she is not well. So what it could be, if they have something in her leg, this is easy. So what it could be? Anyone? Of course, not mitral valve pneumonia. Say again?
Pulmonary embolism.
Yeah, so it is pulmonary embolism. Sometimes you have the same scenario, and they mention this patient has the antiphospholipids type 3 or have protein S or protein C deficiency, because usually to have DVT or pulmonary embolism in young age, you must have abnormal coagulopathy. Okay, so after that, we have this type of question. Is another question. It is about 63 years old man has history of collocation that has been present for many years. Is recently evaluated in the clinic, and duplex scan shows that 85 stenosis of superficial femoral artery. It is important to know the common site of the ischemia, whatever the age, is atherosclerosis, and the common site is the end of femoral artery and the beginning of popliteal artery. 2 weeks later, presented with 1 hour history of severe pain in his leg. On examinations, absent pulse of affected leg, and is much cooler than contralateral limb, so it is ischemic. The process account for this presentation. Okay, so he just need to know what is this. So it is thrombus, it is embolus, something like that. Okay, so the easy way to remember, if we need to make it embolus, what we put in the scenario. If we need to make embolus, usually we put this patient have atrial fibrillation. Patient have atrial fibrillation, whatever the age, and suddenly develop abdominal pain. It is mesenteric vascular occlusion. Suddenly develop lower limb pain. It is ischemic limb. Suddenly develop ischemic colitis. Suddenly develop stroke. So we know that AF, atrial fibrillation, goes shower if emboli, so it is embolus. So this patient have no AF. So what happened to him is thrombosis. So this is a case of the thrombosis, most probably due to atherosclerosis. Okay, so this is thrombosis, not embolus. Subintimal dissection occur traumatic, and it is common due to put a cannula, big cannula in femoral artery. So you can find the patient develop pseudofemoral aneurysm later. So subintimal dissection iatrogenic occur due to insertion of a needle. Atheroma, it can one of the process of development of the atherosclerosis, but is not a thrombus, not the embolus. Of course, anemia not related. All right, simple question. 14 years old boy, brought to the clinic. He gave a history of difficult, painful defecation with bright red rectal bleeding. So painful, so it is not a cancer. Young patient, 14 years. Bright red means that it is from anus. Rectal bleeding. So what is this? So it is just painful rectal bleeding, fresh blood. So what's your diagnosis? Anyone? Simple question.
Anal fissure.
Okay, yes, correct. If you go to one by one, every malformation usually occur in old age, and you have something called angiodysplasia occur after age of 70. So not occur in young. Juvenile polyp, you see the polyp. Hemorrhoid is a hemorrhoid. Can be same picture, but you see the swelling. Intussusception give different color. We call red currant jelly. So the only painful bright red is anal fissure. Of course, fissure in pathology is anyone what we consider fissure in pathology, in the term of pathology, pathological term of fissure, what it could be? Of course, fissure is cracking of the lining mucosa, like defect in lining mucosa. So in pathology, what we called it, what we consider? We consider in pathology as type of ulcer, because definition of ulcer is loss of the continuity of the lining epithelia or the skin. So fissure can be recognized as one of the type of ulcers. Next question, 12 years old, has a history of rectal bleeding. The parent noticed that post-edification cherry red region is present at the anal verge. Cherry red, like cherry tomato or very small. Which one of the following is likely the cause? So something protrude, very tiny, like cherry tomato. So what it could be? Anyone? Of course, not hemorrhoid, not interception,
Polyps,
not
bro.
EV malformation. So it is juvenile polyp. Of course, ulcerative colitis not presented by cherry lesion. Next question is 42 years old, is brought to colorectal clinic with a history of rectal bleeding. Alter bowel habit, weight loss, malaise, abdominal examination, direct rectal examination is normal. CA, carcinogenic embryonic antigen, is normal. So till now, we can consider cancer colon. But he mentioned carcinogenic embryonic antigen is normal. And of course, this is a British man. So straightforward, what's your diagnosis?
Ulcerative colitis.
Yeah, so this is ulcerative colitis. Okay, of course, it is one of the options, very important because it's common in England. Next question, 12 years old, the history of splenectomy after abdominal trauma as regard of his immune system. What is the following process facilitate phagocytosis is affected? It's important to know if we remove the appendix secrete a substance called opsin. This is opsin, coated the capsulated bacteria, and phagocytosis of this process, because it secretes opsin, we called it opsonization. Okay, so it is some sort of phagocytosis. We called it opsonization. It is important to know after splenectomy, because of the lack of opsonization, we give the patient vaccination. We called it roughly pneumo vaccine, but actually it is not pneumo vaccine. It is pneumococcus, meningococcus, and H influenza. So it is triple vaccine. The lay people called it pneumo vaccine or pneumovax, but it is triple vaccine. It's important to give the patient as soon as possible for emergency trauma, and in the elective operation, we give it before surgery. It's very important. In the past, before we discover this vaccine, we need to give the patient long time, maybe 9 months, in some books 2 years, in some historical book forever. We give antibiotic for a long time, but nowadays we have vaccination. 55 years old man undergo colonoscope. Colon polyp is identified. Is lobular appearance located in the stalk of sigmoid colon. Superficial layer shows cellular malignant change, but no invasion of basement membrane. Because if invades the basement membrane, we call it cancer. Not invades basement membrane, we called it carcinoma in situ. If it is more superficial, we call dysplasia. So dysplasia is the answer. This mean bad, plasia means cell. So it is bad cell, mean have all character of malignancy. Nucleus is deeply stained nucleus, hyperchromatic activity, but not invasion of the basement membrane. So we called it, if superficial dysplasia is affect the bone layer, we called it carcinoma in situ. If affects the basement membrane, we called it cancer. Okay, next question is related to embryology. Newborn infant noted to have unilateral cleft lip. So we have cleft lip, we have cleft palate. If you have incomplete fusion of nasolabial muscle ring, so it is lip. But if you have something affect the palatine area or secondary plate, we consider is cleft palate. So we have cleft palate and the cleft lip. Of course, lip is just affects the muscle. After that, we have something related to ENT again. By the way, in pathology and anatomy, and even in surgery in general, we have a lot of questions related to head and neck because the MRCS part 1 is including both general surgery, all surgical specialty, and ENT. 8-year-old child presented with enlarged tonsil that met in the midline, covered with white film, bleed when you attempt to remove. Feverish, otherwise well. What is the cause of the following patient presented with pharyngitis? So just think simple. This patient have pharyngitis or have enlarged tonsil. So what is your diagnosis? Think simple, easy. Anyone?
Bacterial tonsillitis.
Yeah, it is tonsillitis. So why it is not quinsy? Because quinsy is unilateral. So it is not a quinsy. Quinsy is unilateral. Okay. Maybe the next one, or next one is different. A 10-year-old child presented with enlarged tonsil, met in the midline, or pharyngeal examination confirmed the finding. Particular hemorrhage affect oropharynx. On systematic examination, he noticed have splenomegaly. Of course, we know that tonsil is one of lymphatic system, or reticuloendothelium system, or lymphoreticular system. Spleen the same. So we found spleen is enlarged, sometimes the liver or jaundice, and the lymph node and tonsil. So this gives a picture of the infection mononucleosis. Infection mononucleosis caused by Epstein-Barr virus. Epstein-Barr virus in China gives nasopharyngeal carcinoma. In Malaysia and Middle East give infection mononucleosis. In Africa, in black races, it give Burkitt lymphoma. Usually characterized by jaundice, splenomegaly, and jaundice and general lymphadenopathy and tonsil enlargement. Back again, 19-year-old man, sore throat for past 5 days. Over the past 24, he noticed increased and severe throbbing pain in the region of the right tonsil. So only one tonsil. Feverish. On examination, he noticed that swelling in this area, so only one tonsil. So what is this patient presented with pharyngitis? So the cause is quinsy. So again, quinsy unilateral. Acute tonsillitis or tonsillar infection or bacterial tonsillitis usually bilateral. So quinsy is just unilateral. Okay. Something not related. What is the following tumor most likely to give rise to para-aortic lymph node? So again, para-aortic lymph node enlarged in male, testicular tube. In female, ovary and fundus of the uterus. And it is common one of the exam. So fundus of the uterus, ovary, para-aortic lymph node. Testis, para-aortic lymph node. Uterus, internal iliac or iliac lymph node. If you come down above the hymen in the female, iliac lymph node. Below the hymen, superficial inguinal lymph node. In the anus, above the dentate line, in the iliac lymph node. Below the dentate line, superficial inguinal lymph node. Skin of scrotum, superficial inguinal lymph node. Testis, para-aortic lymph node. So we back again to murmur what we discussed before. Again also. 35 years old, Singaporean. And again, they consider that Asian, like Singaporean, Indian, can have rheumatic heart. So attend a varicose vein preoperative clinic. On auscultation, mid-diastolic murmur. Here, he mentions the site, and it is important. So this murmur at the apex of the heart. So at the apex. The murmur enhanced when the patient lies to the flat lateral. So this patient have mid-diastolic murmur at the apex of fifth intercostal space. So this is area anatomically is for which valve? Anyone? Left side, it is mitral valve. In mitral valve, we can have mitral regurg. Mitral regurg give pan-systolic murmur, but mitral stenosis, mid-diastolic murmur. So mid-diastolic murmur in mitral area, mitral stenosis. Systolic murmur, mitral area, mitral regurg or mitral incompetence. Okay, back again to the murmur. 22 years old, intravenous drug user. To have femoral abscess. Nursing staff contact the on-call doctor as the patient have temperature 39. He's found to have pan-systolic murmur at the left sternal edge for intercostal space, not fifths. So again, as we mentioned in anatomy, the site of murmur is different than the normal anatomical position of the valve. So this is not a mitral. So what it could be in the fore, just lateral to the sternum, so it is tricuspid. So this tricuspid. So what is in tricuspid? It is tricuspid regurg. Okay, so tricuspid regurg, pan-systolic murmur at the edge of fore intercostal space, left side. So the tricuspid is right side. The anatomical position, the right side for intercostal space, but murmur migrated to be pan-systolic in the left side, just lateral to the sternal edge. Again, mitral in the fifth intercostal space. 82. An 83-old woman admitted for left intratrochanteric neck fracture femur. On examination, they found have ejection systolic murmur at the aortic region. Of course, this is patient is impossible to have rheumatic heart and is still alive till the age of 80 something. So what happened to her? They have something in aorta due to old age, which is like calcification of the aorta, or we called it aortic sclerosis. How to differentiate between aortic stenosis and aortic sclerosis? It is easy. Aortic stenosis occurs in young, and aortic stenosis radiated to the neck, right sides, radiated to the neck. But aortic sclerosis, it is just a calcification of the aorta due to old age, not radiated to the neck. So we can see the scenario. Systolic murmur loaded in the aortic region, so it is aortic something. Most probably can be aortic stenosis, but not radiated to the carotid artery, so it is not aortic stenosis. So what we called it, aortic sclerosis. ECG normal, so this is aortic sclerosis. To summarize, so we have systolic murmur can be mid-systolic, aortic stenosis radiated to the neck. Pulmonary stenosis rare. ASD in baby, congenital anomaly. Holosystolic mitral regurg, of course, you hear it in the mitral area, so the fifth intercostal space. Tricuspid regurg, systolic, not in mitral area, but in the left side, in the sternal edge. Late systolic in the mitral valve prolapse, and it is difficult. Diastolic murmur, early diastolic, aortic regurg in aorta, pulmonary regurg, Stein-Flint, mid and late diastolic, mitral stenosis, tricuspid stenosis, other rare patent ductus arteriosus. So just to know the common related to aorta, mitral, tricuspid. Okay. Back again to simple question. 33 years old man involved in RTA, initially stable, transferred to accident emergency department. On arrival, he is castorized. Castorized means that castor is from latex or rubber. 1 minute later, he's become hypotensive, angioedema surrounding his penis. So this is type of hypersensitivity. So we have easy way to remember hypersensitivity. We have 4 types of hypersensitivity. Suppose I wear a glove for first time in my life. So we have edema, red color. So it is first type of hypersensitivity, what we called it anaphylaxis. But suppose I wear the glove for 20 years and suddenly have this allergy. So it is delay type of hypersensitivity. First type of hypersensitivity is humoral immunity B lymphocyte. Delay type of hypersensitivity is T lymphocyte or cell-mediated. So it is important in this question. If you mention first time, like he put a catheter, so it is delay hypersensitivity, which is type 4. Where is 4? No 4 here, 4 here. 4 latex hypersensitivity reaction. It's the first time, type 1. It is common to mention in gloves. So say scrub nurse working for a long time and suddenly she develops delay hypersensitivity. New nurse, just student nurse, first time to wear a glove, so it is type 1. Okay. Of course, after that, the patient, he know he's latex sensitive, so we use silicone catheter. And we have some glove is not sensitive or not cause allergy. Okay. 52 years old man with dyspepsia found to have gastric ulcer. A Campylobacter-like organism is taken and positive, which statement related likely the causative organism is false. This is question is easy, but I just looking for it. So this is question can become more logic. I just see it, what happened. Yeah. So first, he speak about H. pylori. He mentioned it is false. We don't have this question in exam, but just for teaching. So H. pylori is gram-negative organism, yes, true. It is spiral, flagellated, gram-negative, urine producing. So it is life only in the columnar type because of gastric and duodenum. Gastric and duodenum. Gastric and duodenum, yes, correct. It may be occupy area of ectopic gastric metaplasia. This is correct because in Meckel diverticulum, you can find some gastric cell, and this is why Meckel diverticulum is can consider as one side of peptic ulcer. You know, peptic ulcer can occur in the stomach, can occur in duodenum, can occur in gastroesophageal anastomosis, can occur in lower esophagus in reflux, and very, very rare in the Meckel diverticulum is the Meckel diverticulum have gastric cell. It is produced powerful urease producing, yes, and this urease producing is the test. As you see, this clue test, Campylobacter-like organism, you can find this is normal. Put a tissue here by punch biopsy is become red, so it is positive. So what is wrong? It is colonized, common evidence of fundus gastric on the endoscopy. Of course, ulcer can occur anywhere. Varices can occur anywhere, but ulcer never occur in fundus. Why? Because, you know, the fundus usually empty. The fundus is up. No food. They have air here. So the possibility to have increased acidity and is difficult because of the gravity. So the fundus, you never have ulcer in the fundus. So this is just logic. Just because the fundus, of course, any part of the stomach, so it is pre-pyloric is a common site, greater curvature is a common site, lesser curvature is a common site, not greater, but fundus is impossible. Okay, next question, have a lot of debate. 13-month-old boy is brought to surgical clinic by his mother because his left testis is not located in the scrotum. So this is either undescended or ectopic testis. Which of the following site testis considered an ectopic? Ectopic mean is not in the normal pathway. This is the normal pathway, like become in the abdomen or original position here. Like here it comes scrotum. So can be in the internal ring, can be in the inguinal canal, can be in the external ring, can be in superficial inguinal pouch, can be down. If it is away from this, we called it ectopic. If in this way, undescended. So canicular, inguinal, external ring, superficial pouch is all are undescended. But base of penis is not the pathway, so we consider is ectopic. Okay. By the way, in the some version of this question in the internet and YouTube, they put the answer superficial inguinal pouch, but I review it in many times and in many texts, so it is still superficial inguinal pouch is undescended, and the base of the penis is ectopic. Okay. Just to see if the other, so this is why I put this picture. Very nice question. Splenectomy increase the risk of infection for the following except. This is question he need to ask. Which bacteria is capsulated? Capsulated bacteria, pneumococcal, Klebsiella is called Klebsiella pneumoniae, influenza, meningococcal, all these are capsulated. So which one is uncapsulated? So it is the Staph aureus. So the Staph aureus, no need opsonization. So no need spleen. So it's not affected by removal of the spleen. So again, who is affected by removal of the spleen is the pneumococcal, meningococcal, H. influenza. Of course, pneumococcal have many species like Klebsiella pneumoniae, but others not. We're about to finish, so don't worry. We have only 5 questions. 18-month-old boy presented with recurrent urinary tract infection. As part of diagnostic workshop, he noticed that have abnormal renal function. Ultrasound performed and show bilateral hydronephrosis. Of course, if the patient is old, the patient, bilateral hydronephrosis, it is a straightforward benign prostatic hyperplasia. But it is young, it is a baby, so it's difficult to have a prostate. So what he had something in the area of urethra, so it is urethral valve. See, this urethral valve can cause back pressure in both kidney, and the patient presented bilateral hydronephrosis. Okay. Back again, we speak about chest pain. 52 years old male presented with tearing central chest pain. Tearing central chest pain usually again with aortic aneurysm. On examination, they have aortic regurg murmur. So the murmur is mimic aortic regurg. ECG, ST elevated in lead 2, 3, and AF. So it is also mimic ischemic heart. So you have ischemic heart, have murmur, have severe pain. So the most likely this patient have aortic dissection. He's not mentioned aortic dissection here or what? Proximal aortic dissection. Yes, proximal aortic dissection. So the aortic dissection, of course, it is not diagnosed clinically. It's need to diagnose by echo, and they give or mimic the same picture of the ischemic heart. I think the cardiac enzyme in this patient usually is not high. And this is, if you found the cardiac enzyme is not high and the patient is typical like ischemia, botoneurobind ischemic thoracic aortic aneurysm. This is important because aortic aneurysm is not common in Malaysia, but the only case I see it in Malaysia, it is like this, and they went to the hospital 3 times as chest pain. No one diagnosed her except in the 4th time she did echo, and they found this thoracic aortic aneurysm. Although it is rare, but you can diagnose this. Next question is a 52 years old male presented with central pain and vomiting. He has drank a bottle of vodka. You know, vodka is what we called it Russian wine. So Russian wine is not common in England. But you know that if you don't use for a wine and drink a lot suddenly, you can have severe vomiting and can cause rupture of esophagus. This is called what we called it Bohavi syndrome. So they mentioned vodka because the British people, this is, of course, we speak about British. If we speak in Russia, it's no problem at all. So he drank vodka, which means that this man, he can drink it before, but he's not used for this type of wine. On examination, some mild crepitus in the epigastric region. This crepitus is air escape from esophagus, what we call the cervical emphysema or subcutaneous emphysema. So what happened to this patient? This patient have severe vomiting, the rupture of esophagus, and what we called it Bohavi syndrome. Of course, the common cause of rupture esophagus in other country is just iatrogenic by endoscope. But this just mentions that alcohol drinking, special type of alcohol. In other scenarios, they say young man, 25 or 20 years old, don't use to drink alcohol and invited in Christmas, and he drink a lot of alcohol and followed by vomiting and chest pain. So it is also Bohavi syndrome. Okay, next question. 52 years old male presented with central chest pain. On examination has mitral regurgitation, ECG, ST elevation in lead 5 to 6. No ST elevation in 2, 3, and AF. So this patient now is atypical of the anterior anterolateral ischemia. So the anterior myocardial infarction or anterolateral ischemia. Of course, this is question usually if common exams come under anesthesia or physiology. 78 old lady presented with tender swelling in right groin. So old, usually fatty, swelling in right groin. This swelling is lateral to pubic tubercle, lateral. So it is below the inguinal ligament lateral to pubic tubercle. So what is most likely? So this is the hernia. And in the female, old, the commonest hernia is femoral hernia. Of course, the hydrocelocanal nuke can occur, but in inguinal region, not lateral to the pubic tubercle. Inguinal hernia, very rare, obturator, very rare. Last question. 22 years old man undergoes splenectomy after abdominal trauma. On secondary postoperative day, full count is performed. What is the following blood component is present? Okay, so this is question, the idea. If we remove the spleen, so this is sudden onset for the body. So you remove the spleen, so the body needs to produce a lot of RBCs. So if you make a lot of production, so the product is not ideal. So the ideal RBCs have no nucleus. So what happened to the RBCs? You can find some of RBCs have nucleus. These RBCs who have the nucleus, we call it reticulocytes. So increase reticulocytosis. So reticulocytes usually increase in anemia under treatment or in process of the hemolytic anemia. Of course, during this period, we have a lot of the abnormal cell. The common is Heinz cell or Howell cell. So many names, and all this name is different shape of the nucleus. Okay, so just increase nucleocytosis. This is the last question. So what shall we do for the next time? We have macrobiology. I send you the answer for this, and we have macrobiology and physiology. Okay, so we met in the next Friday. All right.